I think today we have so far a very good seminar, especially because the theme is on regenerative medicine. I think we have a very good in-depth look into the use of HA by Professor Jung, and we have a very good in-depth look at the use of PRP, Professor Lin, and also a very good talk by Professor Liang. And I think Brian gave a very good overview of all the biologics out there, including the use of scaffolds and PMAX. So I'm going to round off today's seminar with the surgical options when all else fails, right? I know there are orthopedic surgeons here, and you know, orthopedic surgeons, we love to operate, right? But like I always tell my department surgeons, we operate only when it's necessary and when it makes a difference to the patients. We certainly believe in all the conservative ways of healing osteoarthritis, including the use of regenerative medicine. In fact, we want to look at all these things that we've talked about in the SGH Department of Orthopedics in what I call a very regulated, in a very scientific way. And so that hopefully we can inform the rest of the world, right? So far, I must say the translation has been fantastic. So thank you to the translators. And I will try to speak slowly so that I make life easier for Soin. I just have Vietnamese copy, so I might end up speaking very fast. I will try. Okay, so now we're going to talk about knee osteoarthritis in the active patient. So by active, of course, it can be across all age groups, including the older patients, right? So it doesn't mean that you're old and you have osteoarthritis is the end of your active lifestyle. There's still so much you can do, right? But there is a challenging problem behind it. One is, do we tell our patients who want to be active to stop exercising? Because if you do, you are going to cause more damage to your joints. Or do we want them to continue with the active lifestyle? Now, the other thing, of course, is do you want to do surgery so that you restore function and lifestyle? Or do you say, maybe we should not exercise after the surgery is done so that you can protect the implants, right? So osteoarthritis, as we all know, actually the rheumatologists are even more, well-versed in osteoarthritis than orthopedic surgeons, right? But we all know that it can be primary or secondary. Secondary can be due to a history of trauma or any other associated secondary causes, including rheumatoid arthritis, which the rheumatologist would see. Is my speed okay, son? All right, so you know they can present with pain, deformities, and all, right? So we often see deformities like what you see on the screen. When we go in to operate, this is what we would often notice. You see very osteoarthritic areas down to bone, and they either present with about various deformity or valgus deformity. Sometimes they present just like this, what we call a windswept deformity, where one knee is valgus and the other knee is varus. Of course, you can get osteoarthritis just in the kneecap, which is what we call the patellofemoral osteoarthritis. Now, so very quickly, because like I say, right, a large part of treatment in osteoarthritis is still non-surgical, conservative. And that includes lifestyle modifications like weight loss, refraining from aggravating activities, making adaptations both at the office and at home. And of course, physiotherapy, right? Physiotherapy, it's important to get the muscles strong, to get the knee supple, so that you don't get a stiff knee, which is painful. And all the various forms of physiotherapy modalities like ultrasound treatment, heat treatment. Sometimes we offer braces or knee guards. It can be very cumbersome. Some of these braces, patients may not like them, but it's an option that you can consider. And of course, what we're talking about today, right? The theme of today's seminar, medical management, NSAIDs, glucosamine, steroid injection, physical supplementation, which we talked about, hyaluronic acid, the role of biologics like PRP, the role of stem cells, VMAX, scaffolds. So now we delve into the gist of this talk, which is what are the surgical options available? Now, so when you have osteoarthritis, it doesn't always equal to a joint replacement. In fact, there are smaller procedures that we do before we even consider a bigger procedure like a knee replacement. And that includes arthroscopy, as you can see here. Arthroscopy, the keyhole surgery. I know rheumatologists here actually do arthroscopy too. Our rheumatologists back in Singapore don't do invasive procedures like this. Osteotomy, which is realigning of the bone. Arthroplasty, which can take the form of either total knee replacement, uni-compartment knee replacement, or patellofemoral knee replacement. Now, I put arthrodesis between brackets because, you know, when you fuse a joint, it is very debilitating. It's very hard for the patient to be happy and to function well. So nowadays, because the materials we use are so good, the implants last longer, we have really abandoned this arthrodesis or fusion procedure. So joint preservation is something we at SGH Orthopedics believe strongly in. That means to say, if we can avoid replacing the knee joint or any other joint, we want to do that so that we can let this patient continue with an active lifestyle. So biologics are important, stem cells can be something we want to look into. But if you need to consider an operation, maybe there are operations that are what we call joint preservation surgery, where you don't replace the joint to consider. And this includes the use of the arthroscope. We go in to clean up, like what Dr. Brian has shown you, we clean up, sometimes we make holes in it. We talk about that in a short while. But this procedure can work if we choose the appropriate patients. That means to say it must not be severe osteoarthritis where it's bone on bone. So preferably there are mechanical symptoms. The duration of symptoms are less than 6 months and you can get good results. So it is not true to say that there is no room for arthroscopy in knee osteoarthritis. In fact, we've done our own study, quite a large number of patients, where we actually just go in through a scope arthroscopy to clean up the knee, and actually they do very well. And a lot of them have avoided a subsequent knee replacement operation. So this is the microfracture procedure that Dr. Brian talks about. So what we do is we make holes in the area where there's a defect. So what we are trying to do here is through this microfracture holes, right? We're trying to reach to the subchondral bone where the mesenchymal stem cells are. And then hopefully this differentiates into chondrocytes, and in turn, the chondrocytes produce fibrocartilage. You may not get hyaline cartilage, but if you get fibrocartilage, we can help the patients. A lateral release is sometimes what we do. So it's also done through the arthroscopic method. We go in and we cut the lateral patellar retinaculum. So you see a tilted patella here. So by releasing this lateral retinaculum, we try to recenter the patella in the trochlea of the femur. And that can again help our patients. Now, this is the paper that Brian was talking about, which we did with the use of Cartifew. Cartifew is just one brand of the cartilage scaffold that we talked about. So if we can play this video, can we play the video right at the bottom left? Is it possible? Who is controlling that? Let's try to, you move your mouse here and see if you can play the video.
Click on it.
Yeah, maybe not. Yeah, I think we will lose some of the other videos too. But anyway, it's just a procedure to show how we clean up the cartilage. So we call that chondroplasty. So we clean up the cartilage. It's hard to control this mouse. Anyway, so we clean up the cartilage at the rims, and then we make holes in it, and then we inject the scaffold. So this scaffold is to trap all the good stuff that I was telling you about, all the chondrocytes producing the fibrocartilage within that defect. And again, the results can be promising. Now, osteotomy is the next procedure to consider if arthroscopy is not suitable or has failed. So osteotomy means we actually break the bone, we realign it. So if it's a varus or valgus knee, we want to restore the alignment of the knee so that the patient now will have not as much weight going through the osteoarthritic part of the knee. So this works usually when the disease is unicompartmental, involving only one compartment. Right? And of course, this is a good procedure for the younger patients because we allow them to go back to almost unrestricted sporting activities. Sometimes we do it with an ACL reconstruction. And now we come to the last bit, which is arthroplasty. So not all patients with severe osteoarthritis will need a total knee replacement. So this is what we call a unicompartmental knee arthroplasty, as most of you here would know. So because this is medial disease, it only affects the medial joint. We put in replacement just on the medial side. So this is good because it's a smaller procedure, patients recover faster, and because the ligaments are conserved. Actually, the knee kinematics are also conserved, and the patients usually feel a lot more natural in the use of the knee. So they can actually do a lot of activities following this procedure. This actually is a video, but we won't play it. But again, you can see knees that are very worn out, both sides in the medial compartment. We did what we call the unicompartmental knee arthroplasty, or UKA. And actually, just within 6 weeks, this patient was walking very well. So it's a gratifying operation to do. We just replace the patellofemoral joint. So if it's a patellofemoral osteoarthritis, you can consider, as the photos here show, just replacing the patellofemoral joint without even touching the main joint. And of course, the good old total knee replacement that everybody is familiar with. And we know for sure that this is a highly successful operation. I think the question here, of course, is when does a patient need to do a total knee replacement? With the advent of all these non-surgical treatment modalities, many of which we talked about today, I think we can delay the use of a total knee replacement for patients. But it's like what Prof. Liam has shown in that very nice slide. You have to catch these patients early, right? You catch them at sunrise when the tree is still blossoming, is good. But when the tree has died, there's no more water for a long time, it can be hard to treat them without surgery. So this is where a total knee replacement, for example, will come into very useful play. This is an example. This is just showing a total knee replacement model. And again, the patient who has a very worn out knee through all compartments, what we call a tri-compartmental OA knee, after surgery can walk very well. Another example, but we won't play the video. Now, the recent advances in knee replacement includes the use of computer navigation. And in the last few years in our hospital, we have been using robotic surgery. I myself use it too. Now we are still doing studies to get a firm conclusion that it is maybe the next best thing. As of now, it's not conclusive. But anecdotally, we find that patients who have robotic surgery done, they seem to have less pain. They certainly have very good restoration of the mechanical axis. As you can see here, even for like this patient with severe valgus knee, this is through the use of robot. This is my patient that we did not so long ago. You can see that the line runs straight through center of hip, center of knee, center of ankle. So the use of robot is something that we are looking into in, like I said earlier, a regulated and a scientific way. Of course, post-op rehabilitation is important. You know, a lot of surgeries we do, as the orthopedic surgeons here would attest to, would not be successful if we don't have our physiotherapists helping us, right? I don't know whether there are physiotherapists in the midst here, but they are certainly an important members of the team. All right, so we need to do muscle strengthening, range of motion exercises, gait training after surgery. Now, this is the interesting part, right? What are the activities that you can do and what are the activities that you cannot do after a knee replacement? So certainly what's considered dangerous would be like maybe running a marathon, high impact sports. Activities that exceed usual recommendations would be like skiing, tennis, Although I have patients who have gone back to tennis, but I always tell them, play very conservatively. Don't run after every ball, right? Don't play like you have to win every ball, right? But you can still play, in a conservative way. But certainly there are many activities that you can do, like recreational walking, swimming, golf. A lot of people play golf in Vietnam. Hiking, ballroom dancing. These are things that you can very much do day in, day out, even after a knee replacement. And this is a survey of surgeons in the West, asking them what they feel are sporting activities that patients can go back to. And there is good consensus that activities like cycling, ballroom dancing, golf, gentle hiking, rowing, things like this can still be done. So there's mention of doubles tennis. So you're not playing singles, running around the court all on your own. So, but the idea or the message here is having a knee replacement done is not the end of your active and sporting lifestyle. So what is the goal of surgery for the active patient? The goal is for patients to remain physically active because that's important for general health. That's important for cardiovascular health. It prevents heart problems, and actually it improves your bone quality, right? You tend to get less risk of getting osteoporosis. And actually, even for the implants, when you exercise, you can actually get better implant fixation. And this is an article, from our Strict Science national newspapers on patients that we did in SGH. And the message again is we do this operation not to just let you get from point A to point B in your daily life. We do this so that you can go back to the things you love to do, like this lady, ballroom dancing. All right, I've come to the end of my talk. Thank you.